Good evening, all. Respected Chairman, sir, esteemed DB members, Dr. Indu Khosla, ma'am, the mentor, and our esteemed moderator, Dr. Kamal Kumar Singhal, the presenter, Dr. Abhinay, and all the dearest delegates. So, welcome for this scientific deliberation, which is a monthly affair, Advanced Pulmonology Clinic. So, may we have the welcoming address of our Chairman, sir.
Thank you, Dr. Modi.
No, sir.
Respected Dr. Kalpanavar, sir, past chairperson of IAP NRC, Dr. Modi, all my EB members, mentor for today's session, Dr. Khosla, today's moderator, Dr. Kamal Singhal, and Dr. Abhinay, and all my dear friends. IAP NRC is really grateful to all of you, all the participating institutes, where they are doing a great service to IAP NRC by presenting this edition of Advanced Pulmonology Clinic almost last Monday every month in the past about 3 years uninterrupted. And these are taken very well appreciated by all the residents and in fact all the practicing pediatricians. And they really appreciate the way in which the cases are discussed and the approach to various disorders in pulmonology is being taught. I think it is unparalleled. So let's hope that this thing continues. I am really grateful to Dr. Kamal Singhal, who is the anchor for this program, and he does this job in an absolutely professional manner, and and he's really doing the job very well. And we hope that we get his services for years to come. Thank you very much. And I think with this, I'll again thank everyone, and I'll pass on to Dr. Modi to start the session, please.
Thank you, sir. And I take this opportunity to welcome our two very esteemed, respected lead discussants, Dr. Sachin Singh and Dr. Anil Sapare. I think he has joined already.
Sachin has
so
joined.
without much ado, I will hand it over to Dr. Kamal Kumar Singhal to start the proceeding. Thank you.
Thank you so much, sir, for the kind words. Rawat sir and Modi sir. So we will straight away start with the clinical presentation. Dr. Sachin is here as a lead discussant. So I will request Dr. Abhinaya to
Yes, sir.
please start with the presentation.
Good evening, everyone. I thank IAP NRC for giving me this opportunity. And I also thank my mentor, Dr. Indu Khosla ma'am, and special thanks to Dr. Tushar Mania sir, consultant pediatrician from Nanavati Hospital. So today my topic is Cobblestone pathway. We are starting with the history. 7-year-old girl child, first by birth order, non-consanguineous marriage, resident of Mumbai, informant being parents, presented with chief complaints of fever with chills, cough, and chest pain for 2 days. History of presenting illness. The child had acute onset fever, which was lasting for 2 days, and it was intermittent, high grade, and it was relieved with medicines. Associated, child also had cough, which was wet in nature and more on lying down position. There was no history of sore throat, cold, ear discharge, vomiting, or breathlessness. The child also complained of left-sided chest pain, which was dull aching, diffuse, non-radiating, and relieved temporarily with medicines and increased on coughing. There was no history of any palpitation, syncope, trauma, or cyanosis, and there was no history of choking or foreign body ingestion.
Dr. Abhinay, I will just interrupt you here. Can you please present the presenting complaints again? Dr. Sapare has just joined. I would want him to have a real good look into this.
Sure,
so it's just one slide. So
yes, sir. 7-year-old girl child, first by birth order, non-consanguineous marriage, presented with chief complaints of fever with chills, cough, and chest pain for 2 days. History of presenting illness. The child had acute onset fever with chills. It was intermittent, high grade, and relieved with medications. The child also had cough, which was wet in nature and more on lying down position. There was no history of sore throat, cold, ear discharge, vomiting, or breathlessness. And child had left-sided chest pain, which was dull aching, diffuse, non-radiating, relieved temporarily with medicines, and increased on coughing. There was no associated history of palpitation, syncope, trauma, cyanosis, or no history of choking or foreign body ingestion. After I'm moving on to the past history. The child has a very significant past history. Child was apparently well till 4 years of age, after which child had recurrent episodes of cold, throat pain, and also wet cough. The wet cough was more on lying down position. And during all these episodes, parents also noticed there was swelling of the medial canthus of the both the eyes, more on the left side. And all these episodes were mostly afebrile, lasting for a very long duration of 1 to 1.5 months. And she required antibiotics during each episodes. The child had received multiple antibiotics during the last 3 years, nasal spray, inhalers, and sometimes even nebulization. The child remained well for 1 to 2 weeks, followed by similar symptoms again. There was history of ear discharge twice between the age of 4 to 5 in both the years. And during the same time, the child also had complaints of open mouth breathing, snoring, night awakening, nasal twang. And parents also noticed the child has reduced hearing at around 5 years of age. Following which, the child was evaluated, and in June 2023, when child was around 5.5 years of age, child underwent adenotonsillectomy with bilateral grometube insertion. Even after the child surgery, the child continued to have similar symptoms, and the child continued to have ear discharge during every infection. Open mouth breathing and snoring reduced, but they were not absent. And parents also noticed the child was not gaining weight during the last 1 2 years. The similar episodes continued. In July 2024, she presented with abdominal pain, vomiting, loose motion for 6 days duration, fever with cough for 4 days, and child was initially treated with oral antibiotics. Symptoms were not resolved, after which child was hospitalized. An X-ray was showing pneumonia, for which she was treated with IV antibiotics. During this admission, she was worked up in detail, including genetic workup, and later on patient was lost to follow up, and she presented now December 2024. There was no history of any oily stools or sticky stools. There was no history of choking of feet or foreign body. There was no history of TB contact. There was no history of joint pain, rash, and there was no history of any other hematuria. This is the summary of the past history. So basically, from 2021 till 2024, she had recurrent episodes of cold, throat pain, wet cough, and during each episode, she had swelling of the middle canthus. And since 2022, she developed ear discharge and also had open mouth breathing and snoring, for which she was evaluated, underwent TAR, grometube insertion. And in 2024, June, July, she had GI episodes and pneumonia, and she presented again with respiratory complaints in December 2024. So coming on to the birth history, antenatal history, mother has a known case of epilepsy controlled with 3 anti-seizure medications. Mother has a history of 1 spontaneous abortion, and 1 other sibling is alive and well and good. Child was born full-term LSCS because of cephalopelvic disproportion. Antepartum bleeding was present. Birth weight of 3 kg. Child cried immediately after birth. There was no NRC admission, and child was breastfed for 1 year. Immunization history, BCG scar is seen, and child was vaccinated till 5 years of age. Developmental history, child is studying in 2nd standard, average scholastic performance, and there was no developmental delay. In nutrition history, there was almost 300 kilocalories deficit and protein almost 2 grams. As I said, there was 1 spontaneous abortion, and there is 1 child, female, and she is well, no complaints, currently 4 years of age. And they belong to upper middle socioeconomic strata. Summary, 7-year-old girl child with recurrent respiratory and ear infection with adenoid tonsil removal status with grometube with probable dacrocystitis with failure to thrive presented with acute lower respiratory tract infection.
Thank you, Dr. Abhinaya. Thank you. So I think we will take over from here. There are a lot of things in this case.
Yes.
There is a lot of information which we will take time to assimilate as of now. So a lot has been said. So what we understand is a 7-year-old child and having problems for the past 4 years,
Yes,
which
sir.
means recurrent respiratory, which means chest, ear involvements, one episode
Upper
of
and
diarrhea, upper respiratory infection, diarrheas, not gaining weight appropriately, and one of these things. And he has
yes,
had one sibling death as a spontaneous it was a spontaneous abortion, not a sibling death.
yes, sir.
And the
Yes,
mother is on anti-epileptics.
yes,
And then you say that there were nasal symptoms also,
yes,
along
sir.
with snoring,
Yes, sir.
which required adenotonsillectomy and a
Yes, sir.
insertion.
Yes, sir.
So a lot of things. So with this, let us first of all, I will request Dr. Sachin Singh. Dr. Sachin, any comments on this? Any clarification that you wish to seek in history as of now? If you want to know something more than this, so you can please ask Dr. Abhinaya.
Thank you, sir. It's nicely presented till now. I just want to ask with Abhinay, this it's more likely it's onset is so early, so it will be presented like at the what age child has symptoms started, and it form more particularly in the neonatal period or after that till
No,
infancy.
sir.
How was that?
No,
Because
sir. Pardon, sir.
at what age child exactly started with the
4
symptoms?
years, sir.
How
4
the
years, sir.
last 1 year, first 1 year, how was the child?
According to the parents, child was growing well in the first year of life, and there was no complaints. All these symptoms they noticed only after 4 years of age. And
Okay.
even the records are showing that the child didn't have any frequent hospital visits at least till 4 years of age.
Okay. We'll probably be dealing with the multi-system involvement, and which we'll later discuss.
Okay. Should I move on, Dr. Sachin?
Yes, sir. Any other, if anyone want to come in?
Okay, Dr. Sapare, sir. Dr. Anil Sapare. Sir, you are muted, sir.
Yeah.
Yes. Again, you are muted, sir.
Now I'm audible.
Yes, you are audible, sir.
Yeah. Abhinay, it was good presentation. Can you elaborate on what was those symptoms of upper airway?
Yes, sir.
Was it fitting like a OSA, or was it fitting something like a UARS? And why was the symptom so bad that why was it led to adenotonsillectomy? And how was the child before and after this thing? And do you think there is a link between that and the current symptoms?
Yes. So, sir, the symptoms all started with cold, and then there was some throat pain noticed. So, but as the child was around 4 to 5 years of age, the parents noted the child had persistent open mouth breathing and snoring was noticed. So, definitely the child had a OSA component. And also because the child was evaluated and tar and grommet tube insertion was done, child also had a documented hearing loss. So, for which been and they also had put grommet tube. After putting the grommet tube also, during all the respiratory infection, she continued to develop ear discharge because the grommet tube were there in situ. She had offensive ear discharge. And regarding the current symptoms, so I would like to relate because a child and not growing well, initially having more of upper airway and now presenting probably with lower airway infection, I would definitely want to relate the two all these episodes.
And ear discharge started after adenotonsillectomy or
No, sir.
before?
Even before the surgery, she had 2 episodes, and after the surgery, because the grommet tube was in situ, during every infection, she continued to have discharge, and it stopped like recently. Now the grommet tube is not there, and that stopped now.
No, is this symptom complex one that belongs to just a allergy complex, or is it that just belongs like a obstructive pathology? What I mean is, what do you mean by recurrent cold? Was it meaning sneezing, rhinitis, itching?
It was no, it was more of a kind of nasal block, and then initially started with runny and then nasal block, sir. It was more of nasal block.
So there was no allergic rhinitis like symptoms.
No, sir, there was no. No sneezing or
No
itching.
itching, no
Yes,
throat
sir.
irritation,
No,
because you
yes, sir.
mentioned some
But she
throat.
had throat pain. Yes, sir. Throat pain. Yes, sir.
And did the symptoms of snoring, breathing, mouth breathing, all those things settled after the procedure?
No, sir. Partially.
So she
There
had a
was some
partial.
improvement, definitely, but not completely gone. There was definitely some improvement.
Okay. And this swelling which is there in the medial part of this thing, what you considered as dacrocystitis, how long that was lasting and what was making it better after the each time child has these respiratory symptoms?
Yes, sir. Sir, according to the parents, so every time when she develops cold and cough, she would get swelling, and then it would subside with the illness. But again, they would say that whenever she gets a swelling, they know that okay, now she's going to get an infection. So it was always accompanied with the respiratory symptoms, sir.
No,
And they
no.
were not there before 4 years of age, according to parents. There was no watery or any discharge even prior to that.
No, what I'm trying to say is, if I have to think that it is an infectious process like dacrocystitis, so was there a pain, swelling, and redness, or was it just that the terminates are swollen and it is causing the obstructive to the pathway and they are mildly getting swollen? Is it
Yes,
really
sir.
pathologically enlarged, or
Sir,
was it a mild?
it was mild, sir. Parents noticed enlargement and then some redness, but not very sticky eye discharge or anything, sir.
Okay, okay, that's fine.
Yes.
Thank you, sir. So, Dr. Abhinaya, what Dr. Anil Sapare is trying to ask is that the symptoms
Can I
would
add one point here?
fit
Because I had seen the
into
child
more.
first. Can I add a point here? So this the medial canthus used to be tender when she used to get the acute problem. It used to be quite tender. It used to be swollen, and there used to be a lot of sticky eyes.
Okay, madam, that's useful information. Thank you.
For the audience, if we have to differentiate between allergic rhinitis and sinusitis based on history only, not on examination, points will suggest that if suppose the discharge is clear, watery, it goes more in favor of a rhinitis. If it is thick, yellowish kind of a discharge, it may suggest bacterial sinusitis. And of course, then other features like itching, sneezing, some postnasal drip, these are more associated with rhinitis than sinusitis. And then, of course, pain, the facial pain, the headache, the fever, they all suggest a bacterial sinusitis kind of a thing. Although based on history or even on examination, it is very, very difficult. Rather, based on history, examination, and the radiological investigation also, it at times becomes very difficult whether it is allergic rhinitis alone or an untreated rhinitis going on to have a bacterial infection. So if suppose we have clear pointers that it is rhinitis, at times it may be there, but sometimes it can be very, very tricky. Dr. Sachin, you have raised your hand.
So one thing I want to know that whether these wet cough patient have wet cough, whether they have recurrent episodes or in between, where they have some baseline and then it's an intermittent kind of thing, and whether it's persistent nasal discharge or any.
Very pertinent question. I think, Dr. Abhinay,
Yes,
what
sir.
we are trying to know is are these episodes, or it's a symptom which is persisting with in between worsenings?
Yes, sir. I understand. So according to parents, it's almost persistent because the child every time required antibiotic. Maybe child is well for
Got
almost
it.
one
So
week,
it's
1.5
persistent.
almost
Got it.
persistent.
So
Yes,
the
sir.
question is this cough associated with significant production of sputum or no?
Yes, sir.
Okay, so we have a persistent kind of a cough, which in between worsens, and it is associated with a wet kind of it's a 7-year-old child, a kind of a persistent cough. Any blood during this coughing?
No, sir.
Is
Nothing.
it there? Okay, fine. There are some questions in the chat box. I'll take them up. One, is this swelling in the eye painful? And how long did it last?
I'm not very sure if that was painful. And generally, according to the parents, it is there in the beginning of the illness and then it reduces again to start again.
Perfect. So is
Yes.
she, we have seen that she's never absolutely well in between episodes. That is the question. Second, is there any family history of atopy till now?
No, sir. Not, I could not
Okay.
elicit.
And how long will the antibiotics be needed before the child responds?
So according to the parents, they would initially give symptomatic, they would go to doctors, initially given symptomatic management. And only when finally when antibiotic is started, at least 7 days, she feels better, only to be well for 1.5 weeks to fall sick again.
So I'll tell you why this 7 days, 14 days, or 3 weeks is important when we talk about this productive cough going on and needing antibiotics. We'll come on to that. So
Yes.
I think one more chat box question. I think persistent in this, the symptoms are persistent and severe. I believe this is what you wish to say.
Not too severe because the child was never required hospitalization other than one pneumonia. The child was kind of coping up without an hospitalization.
Perfect.
Yes.
So is he on any nasal steroids or inhalers?
Yes, sir. Child was prescribed Invitin. It was all intermittent, multiple times inhalers and nasal sprays prescribed, but not to help.
Was there any response to that?
No, sir. According to parents, there was no response.
Sir,
And only antibiotics settle the episode.
Okay, Dr. Sachin, do you wish to ask anything else?
I just want to, based on history till now, what are the possibilities kept?
Yes, we will come to that. She has made a table. She will present that table. So if there are Dr. Anil Sapara, you wish to ask her, sir?
No, if she has made a table, let us move on. And
Yes,
then
she has made a
discuss
table.
that.
We will straight away go on to the table and then let us see what else do we. Yes.
So when this child came to us in December, we were thinking like this child has recurrent adenotonsillar hypertrophy. With OSA, with nasolacrimal duct obstruction, with recurrent pneumonia. This was our working diagnosis. So we were first thinking in terms of mucociliary disorders like primary ciliary dyskinesia or cystic fibrosis, because the child is now having recurrent wet cough, cold, ear infections, requiring Grome with hearing loss, failure to thrive. But what was against this is, according to parents, child was well till 4 years of age, and there was no oily or sticky stools, and according to them is mostly like episodic symptoms. Second consideration was immunodeficiency because of recurrent all these respiratory infections and one GI episode. But again, what was against is the child, according most of the episodes were afebrile, child was well till 4 years of age and less other organ involvement. Because there was upper and lower track involvement, we were also thinking in terms of, is it something like GPA, granulomatosis with polyangiitis, because child is having upper respiratory, lower respiratory with eye, ear symptoms. But again, there was no other history of rash, joint involvement, urinary involvement, or any other system involvement. Structural abnormalities were considered, but again, that doesn't explain the upper airway symptoms or the ear symptoms. And child was well at least till 4 years. Asthma with AR, we kept it as very least probability because it didn't fit. In fact, they were more against rather than for it, because the child had wet cough, which is generally not seen with asthma with AR. And then the symptoms were not relieved. According to the parents, they were not relieved with any nasal spray inhalers. There is a red flag sign of failure to thrive. And then we attribute the cold symptom more to the adenotonsillar hypertrophy rather than the rhinitis per se. And TB, we also keeping it little low because they were more of kind of a recurrent symptom, and the current symptoms are acute onset of complaints, and there is no history of TB contact.
So just if we, Dr. Anil Sapari, sir, you want to wish to add something here?
Yeah, just teasing out each one of them, Abhinay.
Yes, sir.
Let us move on to just first one that you have placed, primary ciliary dyskinesia. If you just put Picadar scoring, what are
Yes.
the points that are there in this particular
Yes, sir.
child
So
that will put in the for box, and the factors that are there in that will be against it?
yes, sir. So in Picada scoring, the first criteria is child should have wet cough in the infancy, but the child is not fitting. But if you see the rest of the criteria, the child should be term gestation, which is correct. There should be NICU admission or any neonatal respiratory distress which the child didn't have. There should be either presence of heart disease or any situs inversus which the child didn't have. What is positive is the child has persistent ear symptoms and the upper airway symptoms. So I think the score should be 3, though I have to see the chart again.
Just a comment. The first fundamental things before we start taking Picador score is daily wet cough.
Yes, sir.
If the daily wet cough is there, then proceed for Picardar scoring. Here,
Yes,
what
sir.
you're saying is for 4 years, child was symptomatic and then symptoms have started. So that
Yes,
is
sir.
slightly against that, but
Yes,
still
sir. Yes,
we
sir.
have to keep a possibility. And
Yes, sir.
with respect to cystic fibrosis, yes, polyps in the nose, but your story is saying it was predominantly adenotonsillectomy that was the cause, but complete absence of other GI symptoms and other things. So
Yes, sir.
you have said for and against. So what is the diagnosis that you are placing? First diagnosis and then DDs.
So currently, the child definitely, if this is going to be pneumonia, this will be a kind of a recurrent pneumonia with upper airway symptoms, sir. So child has adenotonsillar hypertrophy with recurrent tonsillitis with OSA, with probable nasolacrimal duct obstruction with recurrent pneumonia.
So recurrent pneumonia, that's fine. The possibilities being?
The possibilities being mucociliary disorders is what we first thought. Then our second AD was immunodeficiency, sir.
Okay. Okay, sir.
Okay, thank you, sir. Dr. Sachin?
Dr. Abhinay, I think your working diagnosis should be the first which one you want to keep, like primary cystic dyskinesia and next to the cystic fibrosis, because your doesn't include your working diagnosis like tonsillar adenoid hypertrophy, tonsillitis, or OSA. These are part of some disease rather than these are the main diagnosis for these.
Yes, sir. Yes,
This
sir.
should be two separated columns like primary cystic dyskinesia and next is the cystic fibrosis, because you can't same. It's mentioned in the books that mucociliary disorder, but these are totally entirely different disease spectrums. Okay, the
sir.
child have you already said there's a persistent wet cough that must be most likely is fitting in the primary cystic dyskinesia as the first possibility, because the child have upper pulmonary infections along with wet cough. So my first differential with the primary cystic dyskinesia and the latter. And cystic fibrosis is lower possibility because these children do not have usually ear complaints. They have more predominantly of this lower respiratory complaint along with malabsorption symptoms. So the index case have more ear problems along with this wet cough and failure to thrive. The first possibility with the primary cystic dyskinesia, and then it should be kept immunodeficiency if you want to kept. Other like asthma with AR and tuberculosis should not be included in these table because they are not fitting in those
Yes, sir.
criteria.
Yes.
Yes.
Sir.
Thank you, Dr. Sachin. I think we all agree that the last four, the first two are the ones which are more relevant here. The rest will not be fitting if you look at the overall clinical picture. But Dr. Abhinaya, you see a 7-year-old child symptomatic for the past 3 years, and you say that the symptom never go off. He continues to have wet cough. Okay, so this is, I think, more like a persistent pneumonia rather than a recurrent. Recurrent is when you have in between, when the child at some point of time gets asymptomatic, but you say he is never asymptomatic, in between has worsenings. So it is a thing like a suppurative kind of a lung disease if suppose there is a wet cough which is going on. So
Yes.
Dr. Sachin, the point that Dr. Sachin is trying to make is that based on history, we have to collect things. At some places it is called the database, where you which is a summary of all the history and examination, and based on then you think of differential diagnosis. But here it is not just the nose which is involved, it is the lungs which are involved, and going by your history it looks more like a suppurative kind of lung disease which is going on in addition to the nasal symptoms. 2-3 things. See, if diarrhea has happened, ear discharges have happened, so that is something that takes you towards probably immunodeficiency rather than PCD per se, primary ciliary dyskinesia per se. If he has diarrheas, if he has more than one system involvement, so diarrhea is something which is not very fitting into PCD. It can fit into immunodeficiency. But yes, your rest of the possibilities seem so. According to you, it is some kind of genetic disorder or an acquired disorder or congenital, or what do you think?
I feel it's kind of a genetic disorder. And as you said, sir, it's like a suppurative airway disease. Yeah. Because
Yes,
the wet cough just partially responds to antibiotics, but again, the child is well only for 1.5 weeks and then to fall sick again.
Sir, can I, sir?
Yes, sir, please, sir. Yes,
So,
Dr. Anil Sapare,
sir,
sir, please.
myself, Dr. Kar. Yeah, sir, like any, till now, you isolated any organism like a throat swab or anything culture you have done?
Sir, we are
For-
at history as of now. We will present the examination
Okay.
and then we will present the
Okay.
investigation. So we are trying to see, we are spending
Is-
more time on this because we believe analysis based on history. And if you can think of differentials based on history, only then the investigations, relevant investigation can be sent or they can be interpreted.
Okay.
So we
Sir,
spend more time
history-wise,
on our history thing.
Abhinay,
sir. History-wise, I'm coming, sir. History-wise, actually, the symptoms are started at 4 years of age. Here, atopy, based on the history, atopy like is not suggesting actually. Rather than primary celiac dyskinesia, sir, each and every episode is triggered either by a bacterial or the viruses. So the case is going towards the possibility of immunodeficiency rather than the primary celiac dyskinesia. What I think, sir. Primary
Okay,
celiac
your point.
dyskinesia because usually, yeah.
Your
Because
point well taken.
every episode, and there is also failure to thrive is there. So that because each and every time it is triggered by some organism which is taking a long time either clear by antibiotics or something with a failure to thrive, rather than the possibility of primary celiac dyskinesia, this is going towards the immunodeficiency, sir. What I feel.
Okay, point well taken. Now we will proceed with the Dr. Anil Sapare. You wish to add? You wanted to add something, sir?
On the last slide of the presentation, just is it possible, Abhinay, just that calf? What was the nature? Was it early morning you mentioned?
No, sir, I worsened on lying down, I had mentioned, sir.
Worsened on lying down. Okay. What does that actually mean?
I mean, it's more like a suppurative or bronchiectasis where because of the postural, it's kind of worsening.
So, no, how do you explain that? To just, what do you mean by that?
So the child's cough is worsened on lying down position. So because of the posture, there is more gravity, and then there is more. I mean, I don't know how to explain, but it's more like kind of a bronchiectasis kind of picture.
No, I understood. Why do
Yeah.
bronchiectasis children cough with change in the posture?
Because the secretions get drained to the main airways and then they cough out the secretions.
Change in the position mobilize the secretions that are distally into the central airway where the cough
Yes.
receptors are there and make. So the moment child moves from left to right, right to left, so it's already that is pointing. But you said that child was well for 4 years and symptoms started and is continuing for last 3 years. Could
Yes,
there
sir.
be some event that has happened at 4 years in the form of severe infection to start with that has caused either destruction of a part of the lung, which is now responsible for recurrent infection? B, could there be a silent aspiration of some foreign body or something? Or C, because of chronic upper airway obstruction syndrome, child has aspirated and had led to, rather than these all possibilities we have put up, because all of them generally starts with infancy and progresses. Though there are various genetic natures which have different ages of onset, and there are variations in the age of onset of all these genetic disorders. Could that be those possibilities? An insult that has happened, and now that lung destructed is manifesting with suppurative lung disease.
Sir, history-wise, I couldn't get any insulting at before the or at the near 4 years of age. But sir, there was no history of any choking on fees or no history of foreign body ingestion that I could get off. And as you said, yes, sir, the child definitely had lot of upper airway symptoms, and but I'm not sure if that had led to the secondary symptoms.
Yeah, one thing it is fine to believe that these are all one syndrome, but a lot of children who comes to your OPD have got OSA.
Yes, sir.
But they do not have lower respiratory tract. This
They do
child
not
might
have
have,
suppurative
and
diseases.
a lot of children who have got foreign body aspiration, there is no history, only examination or something. So could that still be a possibility? Ignored, forgotten foreign body, and that has.
Yes, sir. They could explain the lower airway symptoms, but cannot explain the upper airway symptoms.
Agree with you. Agree with you.
Yes, I think it is too beyond that. We have more than one system involved. So a simple foreign body is not likely to be the culprit here. So let's proceed with the examination. Dr. Abhinaya, please.
Yes, sir. So on this current admission in December 2024, she was febrile, she was little tachycardic, peripheral pulses were well felt, respiratory rate was 24 per minute, there was no distress, saturation of 99% in room air, BP was 96/60 in right arm, there was mild pallor on examination, and cervical lymph nodes were palpable in level 3 or 4, 1 to 2 centimeter, they were non-tender, there was no icterus cyanosis, clubbing, or pedal edema. Anthropometry wise, she was falling in minus third centile both in height and weight, and BMI was in the 15th centile. On seeing the old papers, I was able to find her old growth charts, which when we plot in the growth chart, if we're able to see in the middle growth chart, initially the child's height and weight, height was at least in the 50th centile to start. Later, it was falling in the hello. Am I audible? Later, the height was falling to less than third centile. The same wise, the weight was initially between third and 50th centile. Later on, it fell to less than third centile. So she was definitely child was not gaining weight and height in the last 3-4 years, and she was falling in less than third centile. Head to toe examination, she was stented. When I saw her, her left medial canthus was swollen, inflamed, and she had high arched palate. Posterior pharyngeal wall was granular. Dental caries were seen. Nasal mucosa was congested. Bilateral grommet was not seen, and Bu's lines were seen in the nails, and she had a dry skin. Respiratory system examination. On inspection, the upper airways nose was congested, throat granular. Trachea appeared to be in midline. Apex beat appears to be in the left fifth intercostal space, 1 centimeter medial to mid clavicular line. Left lower side chest movement appeared to be reduced. There was no accessory muscle usage, no dilated veins, sinuses, or scars. On palpation, trachea was found to be in midline. Apical impulse in the left fifth intercostal space, 1 centimeter medial to mid clavicular line. Chest wall movement was reduced in the left mammary, and vocal fremitus was increased in the left inframammary and left infraaxillary area. On percussion and auscultation, on percussion, dull note was felt in inframammary, infraaxillary, interscapular, and subscapular. And in the corresponding areas on auscultation, air entry was reduced, crepitations, and then the vocal resonance was increased. All these things point towards left lower lobe consolidation. And other system examination showed cardiovascular system. No murmur was heard on auscultation. 2 centimeter from the right costal margin, and the span was around 12 centimeter. And spleen was 4 centimeter from the left intercostal margin. CNS wise, there was no focal neurological deficit, or power reflexes were normal. So on summarizing, this is a 7-year-old girl child with recurrent respiratory infection, ear infection, with adenoid tonsil removal status, with grommet tube in situ, with diagnosed cystitis, with probable nasolacrimal duct obstruction, with failure to thrive, presented with left lower lobe pneumonia with hepatosplenomegaly.
Perfect. So let us look at your differentials also, Dr. Abhinaya. So what has changed?
So
according to what you had on history, has something changed now?
Sir, actually, for this current pneumonia episodes, thinking in terms of the left lower lobe consolidation with hepatosplenomegaly and cervical lymph nodes, we were thinking whether this current pneumonia, is it because of any atypical organisms like mycoplasma or viral? We were thinking that as the current pneumonia, etiology. But on the generalized picture, now our immunodeficiency came first, followed by PCD, CF, and other diagnoses where we were not considering. So this current pneumonia, we thought it is probably because of any atypical organisms or a mycoplasma or virals.
So I think for the rest, we do not have any specific pointer. So now I'll bring in the lead discussion. Dr. Sachin.
As this already mentioned in the presentation, this current episodes have child some form of infections, probably viral or bacterial, which lead to the left lower lobe consolidation with underlying the main etiology which I have previously discussed. One suggestion to the Dr. Abhinay that these percentile for the weight, not gaining weight or failure to thrive, this should be, if you present in Z scores, it will be more beneficial for you, for patient and for the treating physician. Because if you kept these less than third percentile, maybe the child when on a follow-up, this comes already again and again comes to the less than third percentile. But exactly is if you mention in Z score, it will be more beneficial whether it's growing or not growing.
Okay, sir. Thank you, sir. Okay, sir.
Thank you, Dr. Sachin. Yes, please, if you want, yes.
No, it's fine, sir.
Okay, fine. Thank you. So the idea is that you can make a one-time assessment with this less than 3. But if suppose you wish to follow
Yes,
him
sir.
up, then these exact scores will help you. Dr. Sapare, sir.
Why do you want to just label directly as atypical pneumonia or atypical this thing? Why?
Yes, sir, because there was there was hepatosplenomegaly and cervical lymph nodes, and then that's why, because generally normal pneumonia, like, so generally all these findings are generally not seen, because when we see pneumonia with hepatosplenomegaly, cervical lymphadenopathy, we were thinking more in terms of atypical organisms and virals.
But in atypical, you would have had, yeah, few pointers. I agree. There are systemic features of dissemination in the form of hepatosplenomegaly lymphadenopathy, but you have got focal findings. You have got findings that are
Yes, sir.
confined to one side. And was the child sick, looking unwell, or was it like a walking pneumonia, looking well, comfortable?
Child was not very sick looking, sir.
Okay.
Okay. Dr. Sapare, anything else now, sir?
No, that's fine.
So again, what we are looking at, there are two things to look at in this child. There is something underlying going on for very long, and something which has happened now, which is acute. So there are two things. So if you think in terms of differential, then one would be the cause of acute worsening, which in a child who has, suppose, ciliary dyskinesias, even a viral infection can create problems, because these viral infections can create further ciliopathies. So be it primary ciliary dyskinesia, all those will have more problems if you have an underlying manifestation like that. So even a simple viral, which in another patients may not result in significant illness, in such patients can create a significant pneumonia. Even if you so we have to think in those terms. But to call it an atypical, if suppose the fever is significant, that becomes typical. In an atypical pneumonia, will not have that kind of a high fever.
Yes,
and all. But yes,
yes.
we do agree. Again, we are fighting it out between immunodeficiency versus primary ciliary dyskinesia. And initially, you are putting your money towards PCD, and after examination, you are putting it into the immunodeficiency basket. So this is probably what has changed from history to examination now, because we have very localized signs. One question: were
Yes,
these
sir.
crackles that you? I'll just finish, Dr. Sachin. I'll come to you. Were these crackles coarse crackles or fine?
They were coarse, sir.
Coarse. Dr. Sachin, you wanted to add something?
Just one thing we should have kept in mind: there's the history have only 2 days. This acute complaint have only for 2 days.
Yes, sir.
All right.
Yes, we agree, Dr. Sachin, that our primary goal is to look at an underlying diagnosis, because in all these you can have in between worsenings because of so many things, right from bacterial to viral to fungal, depending on the what. So our primary goal is to hit what is the primary cause. The intermittent worsenings can, as I said, a simple viral can also create a much bigger pneumonia in such children. So Dr. Sapare, sir.
Abhinay, you have analyzed each of these symptoms, and having come to the history and then examination, you have put immunodeficiency. If you broadly see immunodeficiencies, we have T cell defects, B cell defects, neutrophil or phagocytes. If you take each one of them, which one of those disorder will fit with your spectrum of presentation? Well till 4 years, upper airway, followed by persistent lower airway. In this group, which one will fit, and within that, which subtype will fit into your possibility?
Sir,
A very
it's
good question,
mostly
Dr. Abhinaya. This
yes, sir,
approach is good.
yes, sir. It is mostly kind of a not a very severe immunodeficiency, because that's because the child was well, and then like upper respiratory, then lower. It's
Yeah,
more
so you are
looking
saying
like
it
a
is not skin.
CVID. Yes,
So-
sir, not scared, is
Okay,
more looking
next.
like a CVID picture, maybe with some immunoglobulin like IgA, selective IgA deficiency or class switch, looking like kind of a CVIDs where they can have a variable presentation, where they are diagnosed little later. So I think it's more kind of a CVID from the history at least. And
Sure.
there is no granuloma, no skin infections like CGD and other things are not fitting here.
Perfect. So can you
Okay.
proceed, Dr. Sapare?
Yeah, please proceed.
Dr. Sachin, if there is no question, should we move?
Yes, we can move. For the presenter, I one suggestion. If we say immunodeficiency, now it could be very clearly what kind of immunodeficiency we are keeping in the possibilities. Because
Yes.
it's a very broad term. You cannot fix. So you have to be say, like what kind of immunodeficiency, whether it's a as I already told, whether B cell, T cell deficiency, in that what kind of immunodeficiency.
So very point well taken. So Dr. Abhinaya, there are certain pointers on history and examination which can tell you which immunodeficiency it would be. As you said, severe combined immunodeficiency, the child will not last this long. They will not cross even infancy. They will go.
Yes,
They will
sir.
not be able to survive this long. And then, of course, things like the B cell defects, they present a
Yes,
bit
sir.
late.
Yes,
Initially
sir.
the mother's bodies will be there. Thereafter, once they wane, in the late infancy, they can start having presentation. And variable, as you
Yes.
say, common variable is variable. So it can have a lot of variations. It can have extra pulmonary manifestations. So CVID
Yes.
or B cell defects are something which are more likely to present at this
Yes,
age with this kind of a thing. So this is the approach that we are looking at: the age of presentation, kind of systemic involvement. These are the ones that tell you which immunodeficiency would it be. Thank you, Dr. Sachin, Dr. Sapare. Now let's move on to
Yes, sir. So now I will move on to the investigation. On finding the old papers, I was able to get the old X-rays also. This was an X-ray done in June 2023, just before the tonsillar adenotomy. We are able to see the X-ray nasopharynx where the adenoid appear to be enlarged, and this is the chest X-ray. So if you've seen this X-ray, there is still even some haziness in the right parahilar region, and also there is right peribronchial cuffing and some retrocardiac streaking is there. So this X-ray was definitely not normal even in June 2023.
Thank you,
On the,
Dr. Abhinaya. Can you magnify this radiograph that you have? Is it possible? Yes, absolutely. Yes, a bit shift up if possible, because the lower chest is not being seen at all. Absolutely, yes. Dr. Anil Sapare, any comments on this?
No, this clear, as she mentioned, is a very characteristically suggesting that is peribronchial thickening. It's not just a simple normal X-ray. All the bronchi in the hyla and in the retrocardiac area are dilated, is suggesting is chronic inflammatory bronchitis with thickening of the bronchioles. All we can see is this is a chronic process going on since that time, that X-ray. So our assumption or your story that this child is having recurrent problem fits with that person.
Perfect, sir. Dr. Sachin, the same, Dr. Abhinaya, same radiograph. Dr. Sachin, would you want to add something to this?
Nothing, sir. Same as both sir and
Because
presenter.
what I see is that in this retrocardiac region, you have this retrocardiac opacity, and if you look very closely, when she enlarged it, you can see those rounded shadow-like honeycombing here. So these are very early indicators on this radiograph itself that there is some bronchiectasis which is setting in. If you look closely, you will see those rounded black circles there in addition to that white opacity. So these can indicate a bronchiectasis, and add this to coarse crackles, it tells you that this is some bronchiectasis which is developing here itself. Yes, Dr. Abhinaya, please proceed.
sorry, sir. Yeah, and this was the second X-ray when the child was admitted in July 2024. Here we are able to clearly see there is right middle lobe collapse consolidation. At this time, the child was actually evaluated, immunodeficiency workup and other genetic, everything was sent. But unfortunately, the child was lost to follow between July and to December 2024. This was the current X-ray. So here the X-ray is rotated. It's an expiratory film. The right parahilar opacities are still seen, and here we are able to clearly see left lower lobe haziness. Consolidation is clearly seen this time. And on blood investigation, HB was 8.3. counts were 17,850 with neutrophilic predominance. Platelets were normal. CRP was 241. Blood culture was done. Streptococcus pyogenes was isolated. Child was started on co-amoxiclav, and then she was responding. Her fever spikes were reducing. And immunodeficiency workup, which was sent earlier, we got it. So here the immunoglobulins were actually within the normal range. IgA was 136. IgE, IgG, IgM were within the normal range, and sweat chloride was normal. Now we got the LSSA report. So if we see, total B cells absolute were decreased, pre-germinal B cells were decreased, post-germinal center B cells, they were decreased, and there was decrease in the almost lower limit of the normal was the absolute T cells, and there was again decrease in the CD4 count, CD8 absolute counts, but there was increase in the effector CD8 positive cells. So there was absolute lymphopenia along with relative reduction in many lymphocyte subsets. So then because in this current admission, we wanted to know because of this immunodeficiency status, we definitely wanted to know her the organism which was causing this pneumonia. Considering that, we proceeded for a bronchoscopy. If you see, I shall pause it.
I think Dr. Abhinay, you can take them directly to trachea, then to the main
Yes, sir.
bronchi bilaterally.
Yes, sir.
So because it's a
Yes, sir.
longish video.
Even if you see the upper airways, all these epiglottis, and then all these upper airways were all looking very edematous granular. If we see the trachea, there are a lot of nodularity and granularity were seen. And then if we see all the airways, they were looking very granular. It was looking very much abnormal. So what we had done is we took a BAL, and then we took biopsy, transbronchial biopsy from the left lower lobe. If you are able to see, the airways is completely edematous and lot of granularity and nodularity was seen. So the BAL report.
So the video can go
PCR
on. The video can go on. Dr. Sapare, with this video, you have any comments on this? The video yes, somewhere in between.
Yeah, as it is mentioned, the whole of the tracheal mucosa and the lower bronchial mucosa is edematous, swollen, and the distally the airways looks like, because of the airway mucosal edema, it is narrowed. So it is just suggesting that the whole of this airway are chronically inflamed.
Thank you, sir. Thank you. Dr. Sachin, anything that you wish to add to this?
Nothing, save is mucosa, multiple nodular swellings. Mucosa.
Yes. So we have a lot of edema, granularity, which can be there because of a chronic infection which is going on
there is no
over here.
evidence. I would like to more see on the left lower bronchus, because there is.
I think we have been through both the sides, and it is more or less the same throughout. On the left as well as right, it's throughohout every nook and corner of this airways like that only.
There is no pus.
Indicates something. Abhinay, did you get any frank pus on BAL?
No, sir. I don't remember.
Okay.
Yes.
Fine. So let's proceed to the next investigation.
Sir, BAL report was showing adenovirus and rhinovirus. There was no mycoplasma or any other organism. BAL culture showed no growth. A gene expert MTB was not detected. And later on, even after 6 weeks, NGIT, there was no growth. And we had sent for histopathology from the left lower lobe. As we see, there were a lot of lymphocytes were seen. So and the report given by the pathologist was fragmented tissue beds lined by pseudostratified ciliated columnar epithelium with stroma showing lymphoid proliferation composed of large and small lymphocytes along with few bronchial glands. There was no increase in plasma cells, granulomas or malignancy. So the impression was a pulmonary lymphoproliferative disorder. So keeping all this in mind, and we also traced the genetic workup. On genetic workup, the child had heterozygous mutation in the PIK3CD gene, which is
did we miss the CT scan here? Was it there?
Yes, sir. CT scan was little behind. Yes, sir. It is there.
Okay, fine.
So
because
actually, but the report
doesn't matter. So the climax is out then. Because I wanted to tease Dr. Sapare and Dr. Sachin a bit more with that radiology. What would you think of? But now they know the diagnosis. So if we have that CT, we can have a look.
Yes, sir. It is little behind. I will show that first or finish, sir. I'll show the
You-
CT. Yes.
I think it was there before.
Yes, sir. I changed because the order was not correct.
Perfect.
Because
You just show me the
after-
radiology, CT scan,
Yes.
and then we know the diagnosis here.
Yes. I mean, I got the mediastinal window also. I mean, yes. I mean, I shall pause a little.
I mean, in this view, we can see the liver is enlarged significantly.
Yes, sir.
And this one. Can you hold on in the upper zone here on the left side, Dr. Abhinaya?
Sure.
Yes,
Okay,
somewhere here.
sir.
Yes, you can stop. If you can stop here.
1 minute, sir. I shall put the lung window. Yes, sir.
Let us look at the lung window itself.
Yes.
And
We can see
stop here.
bilateral.
Here. Yes.
Yes.
Stop. Can you stop here?
Yes, sir.
Yeah, we can see there is a significant consolidation in the right bronchial area with areas of bronchiectasis coming out. And if we proceed a bit further, you will see that extension of same process. Yeah, there is consolidation and then bronchiectasis
And hold
involving.
on here. Yes.
And
Yes, Dr. Sapare.
we can see the dense collapse consolidation with underlying bronchiectasis in the right side, and similar findings are also noted in the peribronchial area on the left side. So we have got bilateral bronchiectasis more in the right lower zone, and also it is in the left mid zone with bronchiectasis.
So this area, Dr. Abhinaya, that you are showing now, the right paracardiac region, this is the middle lobe. Now we have passed that. The right middle lobe is in the right this now a bit more.
Yes.
Yes. So this is the right paracardiac, which is the right middle lobe here. So this is showing bronchiectasis because the airways are dilated bigger than the artery along with that, and thickened walls. So there are signs of bronchiectasis in the right middle lobe and in the left lower lobes. So more or less the left part is corroborating with the chest radiograph also. So we have a bronchiectasis because the diagnosis is clear now. We all have it. This you can just tell us a bit about before that, Dr. Anil Sapare sir, are you surprised or is it what you had thought of?
No, I mean, this is what we were expecting. The fact that child was having sputum production whenever child was lying, we are dealing with a suppurative lung disease. What you say, a lot of children with immunodeficiency, adenotonsillar hypertrophy, OSA is not a major component per se. Rather, they have chronic rhinosinusitis, suppurative rhinosinusitis, postnasal drip, chronic suppurative otitis media, and then chronic suppurative lung disease. OSA was not a very much a feature of all forms of immunodeficiency from the beginning. So now the fact that it is bilateral, it is extensive, fits with some form of diseases. Still, before we have immunodeficiency report of the final jury, still all those possibilities remains on the list of differential diagnosis if we were not given that immunodeficiency panel, which includes primary ciliary dyskinesia, common variable. I would still put in that order of common variable immunodeficiency, primary ciliary dyskinesia, and then cystic fibrosis on the list of possibilities before we have that immunodeficiency panel report and that final genetic report. Once that immunodeficiency panel is there, then we have got typical findings that suggesting all the B lines are affected in this particular children. Although we are seeing that immunoglobulin levels are within normal range, we need to see whether they are corrected for the age, number one. Number two, it has been done in a reliable unit, number two, and those are the very two important factors. And we need to do subclass also. Sometimes that you see IgG being normal, if you do G1, G2, subclass deficiencies may be there. So in this case, the fact that there were very low pre-B lymphocytes, the precursors, invariably the immunoglobulin levels will be either abnormal or low. Although in that report that you have gone, and this is highly suggestive of suppurative RV disease due to low, not agammaglobulinemia, but hypogammaglobulinemia. Therefore, this child presenting late and chronic respiratory infection that is affecting both ears and lower respiratory tract. So answer is we are not surprised, sir. But before the results, still the order will be immunodeficiency.
I agree.
PCD.
The mental workup has to be done, whatever it may turn out to, because what seems like typical case of something, one odd day it will throw up a surprise. So if you have done your mental workup well, you will have lesser surprises. Dr. Sachin, any final comments?
Sir, I think the message should be, if we keep the possibility of primary dyskinesia, cystic fibrosis, and then immunodeficiency, the workup should be along with that in order. Because if we just send the genetic workup and without working for the primary dyskinesia, the message for public for the practitioner goes wrong. Because any child presented with these complaints, you said the genetic workup and genetic report give the diagnosis not with the way. I think PCD should be ruled out for the appropriate workup, because genetic test may or may not corroborate with these.
I agreed. So the point everybody is trying to make is that we should have a clinical differential diagnosis, and based on that, we should investigate. And I think because they had immunodeficiency up there in their differential, they investigated. So I think what they did was right, because given their thought process, it was up there on cards as per them. Dr. Indu Khosla, ma'am, any comments? Why did you choose this one case? What is the learning according to you?
Actually, this is the reason why we chose this is because it had a little unusual presentation of involving the upper and the lower airway. And if you look at lymphoproliferative disorders of the lung, it is a disorder by itself. Actually, if Abhinaya is allowed to put 2 more slides to review the literature.
I think Dr. Abhinay, you can present these 2 slides, and then Dr. Indu Khosla can add to that.
Yeah, that will be good actually.
Yes, sir. So we had done a review of literature, because after seeing this genetic report, we just quickly read like what was the main feature. So this is actually an autosomal dominant condition. There's a heterozygous mutation, the PIK3CD gene, and they present with recurrent sinopulmonary infection and other infections in early childhood. And they show defect in both E and B cell population, with inability to control infection with EBV and CMV. And their CD8 cells are also skewed towards differentiation and senescence. And these patients, they develop lymphadenopathy, mucosal lymphoid aggregates, and many of these patients also have increased serum IgM, and there is increased susceptibility towards a B cell lymphoma. If you see, this is the quick all the features where they have the recurrent respiratory ear infections, they have lower airway infection, bronchiectasis, they are known to have splenomegaly, and even they are known to have lymphoid nodules in the mucosal surface in the GI tract. And they can also have skin manifestation. And immunology wise, they are also prone to develop malignancies, neoplasms. This is what we find out, and they have increased susceptibility towards CMV and EBV infection. And if we see
I think Dr. Abhinay, because we are short of time, and I think the audience has got the message that how to
Yes,
approach
sir.
such a case. Dr. Indu Khosla, ma'am.
Yes, sir. Yes, sir. Ma'am can now.
So basically, lymphoproliferative disorders of the lung are a class by itself. And if you broadly classify it, it could be benign and malignant, right? From follicular bronchiolitis to lymphomas on the other end. And I think this is a class of diseases which need more clarity. What we see as lymphoproliferative disorders either could follow immunodeficiency, or it is seen post-transplant. And I'm sure Dr. Sapare, where in his unit where they're doing a lot of solid organ transplants as well as stem cell transplants, you actually see a lot of these disorders. So we need to think about these disorders, because the treatment of these disorders is very different. And I feel this child's the swelling of the inner canthus was basically a lymphoid tissue which was obstructing the nasolacrimal duct and causing the problem, rather than having a blocked NLD. And here they are more susceptible to EB virus infections, especially the one with the immunodeficiency, are more susceptible to EB viral infections. And these children also have a risk of autoimmune disorders. This patient of ours is also ANA positive, and we need to work up on that too. And there is a whole group of drugs which can be used, the sirolimus group, which can be used in these lymphoproliferative disorders. So we looked at literature on these disorders, and there is dearth of literature, and therefore the rarity of the case and the odd presentation made us choose this case to present.
Thank you so much, madam. I think we need to congratulate you and your team for an excellent presentation. Just 2 comments from my side on history itself.
Move to the next slide, Abhinay, the last.
Examination, Dr. Abhinay, I think, ma'am, we will be is what we want, because one a rare case we cannot go into very depth of that because it will not enthuse a lot of them. But we have to look at the approach itself. So I think tonsil is something that you could have commented in your examination. It tells you whether it is XLA or no. That is one. And then chronic suppurative lung disease, it should be somewhere there in your summary or your differentials somewhere. So chronic suppurative lung disease or bronchiectasis could have been there. And lastly, we are here to look at the root of the tree. There are branches here, branches which indicate stridor, branches which indicate bronchiectasis, branches which indicate diarrhea, persistent pneumonia. You know, these are branches immunodeficiency. If you look at that, so I think it is over from my side. Thank you so much. I thank my lead discussant, Dr. Anil Sapare, Dr. Sachin Singh for giving very valuable comments, and Dr. Indu Khosla ma'am for an excellently mentored case, and Dr. Abhinaya for a very, very nice presentation. Thank you from and over to Dr. Modi and Dr. Sanjeev Rawat sir from my side. Thank you so much.
Thank you so much.
Indu Khosla madam, very nice case. It was a good learning experience. I mean,
can you just please stop sharing, Dr. Abhinay?
Yes, sir.
Yeah, wonderful presentation from Dr. Abhinay. Great mentoring from Dr. Indu Khosla ma'am. Fantastic moderation by Dr. Kamal as usual. And great inputs by Dr. Anil Sapare and Dr. Sachin Singh. Thank you all. Thank you, dearest delegates, to have been part of this scientific deliberation. Thank you all. Good night.
Thank you. Good night, all.
Good night. Thank you so much.
Good night. Good night.
Thank you, ma'am.
Good night, sir. Thank you.
Thank you.